Hello and welcome to today's webinar, Cultural Competency in Medical Education and Clinical Practice. I'm Caroline Gumpenberger and I will be the moderator for the webinar presented by the National Healthcare for the Homeless Council and the National Center for Medical Education, Development and Research with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you are having technical issues, you may also call Cecilia Teichert at the Council's office at 615-226-2292, extension 241 for assistance. Thank you, and now I'll turn it over to Dr. Catherine Brown from the National Center for Medical Education, Development and Research. Dr. Brown?
Thank you so much, Caroline. Welcome again to today's webinar, Cultural Competency in Medical Education and Clinical Practice. Our grant at the National Center is HRSA supported, entitled Academic Units for Primary Care Training and Enhancement. The National Center for Medical Education, Development and Research operates under the leadership of Dr. Patricia Matthews-Juarez, the Project Director, and Dr. Paul Juarez, the Center Director. I serve as the Director of Communities of Practice. The aim of the National Center is to address the needs of persons who are LGBTQ, persons experiencing homelessness, or migrant farm workers. We define these as vulnerable populations. Our focus is to translate research findings into medical education curriculum and clinical practice into primary care training and practice guidelines. This is the second of a four-part webinar series through a collaboration with the National Healthcare for the Homeless Council and the National Center for Medical Education, Development and Research. The speakers feature are our NCMEDR Center staff as well as our communities of practice members. Please save the upcoming dates for the next two webinars. March 29th, Trauma-Informed Care for Vulnerable Populations, and June 29th, Harm Reduction, Substance Use Disorders. Today's speakers. The first speaker will be Dr. Patricia Matthews-Juarez. Dr. Matthews-Juarez serves as Senior Vice President for Faculty Affairs and Development, Professor, Department of Family and Community Medicine, Program Director, National Center for Medical Education, Development and Research, Director, Research Training Corps, Health Disparities Research Center of Excellence, Meharry Medical College. Dr. Rueben Warren is one of our COP, Communities of Practice members at the National Center. Dr. Warren is a thought leader and content expert, professor and director for the National Center for Bioethics in Research and Healthcare, Tuskegee University. Dr. Linda Behar-Horenstein is another one of our NCMEDR Communities of Practice members. She is a distinguished teaching scholar and professor, Colleges of Dentistry, Education and Pharmacy, CTSI, Educational Development and Evaluation HRSA Faculty Development Program member from the University of Florida. For more information about the National Center, we've listed our contact information and you can follow us on social media. We've listed our website, www.ncmedr.org, and all of our social media handles. For a quote during this webinar, please follow the hashtag NCMEDR_Meharry, where we will be quoting the speakers during a live Twitter chat. Our first speaker will be Dr. Patricia Matthews-Juarez. The objectives for today's webinar are to state why it is important to become a culturally competent practitioner, to consider how presentation examples can be modified and infused into medical education curriculum, to consider how curriculum changes would augment student understanding of culture, health, and adherence to patient care, and to speculate on transformative changes needed in medical education curriculum to promote culturally competent practices and practitioners. I will now transition to our first speaker, Dr. Patricia Matthews-Juarez. Thank you, Dr. Juarez.
Good morning, Catherine, and our team and the rest of our attendants and participants. This is a very exciting opportunity to talk about how culture and cultural competency really drives what it is that we're doing now and this new decade of teaching medical students, residents, dental students, as well as public health students. This conversation is structured around the concept of culture and the integration of patterns of behavior that include language, thought, communication, behavior, customs, mores, beliefs, values, and institutions of how we look differently and providing care to racial, ethnic, religious, and other social groups. For vulnerable populations, it's a cross-cutting issue when we look at the three groups that Catherine talked about in the very beginning. So when we began to think about how do we reduce health disparities among the three populations, we really need to think about how we are helping students, helping health professionals begin to think about acquiring and integrating knowledge with awareness, attitudes, and skills about culture and cultural differences. Once we began to do that, we can start to think about the kind of activities and the kinds of skills that healthcare professionals must have to provide optimal and expert care to patients from different racial, ethnic, and social economic groups, as well as cultural backgrounds. We have had a long journey over the last 2.5 years looking at the impact of how we provide care to LGBTQ, person experiencing homelessness, and migrant farm workers. And what we've come to understand is that there are several common themes that vulnerable populations, as well as others who may not view themselves as vulnerable, who have access to services, that we all want to be treated with care and humanity. All of us want to be treated with respect. We want to be treated in a system that uses the class standards, where there are pictures that represent us, those of us who come into a practice or into a clinic, into a hospital. We want to see people who look like us or care about the people that look like us, who we are and how we present ourselves in a medical facility. We want to be treated not only with respect, but with a level of trust that the information that we're providing is trustable information and the people that we're providing it to can be trusted as well. For those of us who are LGBTQ, part of our problem is, especially for transition and transgender individuals, the question is not always about whether they have a cold or whether they have hypertension or whether they have cancer, but it's always about the gender-oriented question rather than about the cost. So we hope that in this webinar that we can begin to think about those issues for that population, as well as for those of us who are homeless and may come to work every day. Children may go to school every day, but are invisible because we have no place to stay. And for those of us who are farm workers, who are following the crops or staying in houses or in places where we do not have all of the amenities, and going into hospitals and other places where we are seen as not as equal as others, that we as health professionals began to think really broadly about what we are about, what can we do, and how can we begin to use our cultural encounters in such a way that can be helpful. We want to also help you think about within this context how oral health fits into this broad concept and how ethics also fits. And for that, I will hand this off to Dr. Rueben Warren, who is an exceptional person who works has worked over a long history of time focusing on ethics and bioethics. And Dr. Warren.
Good morning. I'm extremely excited about this conversation we're having. I can't thank Dr. Matthews-Juarez and Dr. Brown enough for thinking through how we make things better for those we serve. I'm also very pleased to kind of listen to the transition where we're learning not only to do the science, that is doing things right, but also to consider ethical constructs of doing the right thing. It's critically important. In February 2017, the National Center for Bioethics and Research in Healthcare at Tuskegee University hosted a conference sponsored by the Robert Wood Johnson Foundation, where we talked about examining ethical and other implications for culture of health in the context of the Deep South. What we recognize is that culture is very important to improving and maintaining health. So we explore those very particular instances of culture within the Deep South in particular. What we realize is that culture drives ethics, and ethics, in fact, drives health and health outcomes. So we're really excited about that transition. What I'd like to explore with you is three fundamental concepts. And the first is really about ethics. Everybody thinks that they are ethical. And while that may be true, one has to operationalize ethics in a way that we can agree or even agree to disagree. And for the context of my comments, ethics is a set of rules, principles, values, and ideals of a particular group of people. The systematic study of morals, concepts, and theories, typically in departments of philosophy. Now, the key component of that definition, and there are many, is a particular group of people. Because we all may see things ethically, but we may see things differently, and we see them through our lens. So as we begin to work with populations, we need to understand their context from which they define right and wrong. Science deals with issues of validity, reliability, statistically significant, but seldom do they really deal fundamentally with issues of right and wrong. Ethics deals with right and wrong. Consider ethics in more than not doing no harm, but doing good. That's a fundamental principle of ethics as we see that. And as we explore further into the notion of ethics, it evolved into this idea of bioethics, which is another important construct, which we think is very, very important in health and healthcare. And we view bioethics, again, many lenses, but the one that we think is most appropriate is ethics. Bioethics is applied ethics, focusing on doctor-patient relationships and how changes in the healthcare system affects it. We really want to understand how the healthcare system impacts upon the doctor and the patient, not only individually, but collectively. The HCA is a prime example of how that doctor-patient relationship impacts upon health and healthcare. So consider bioethics as an important ingredient, not only in health and healthcare, but in the research enterprise as well. Many instances are dealing with bioethics as we move on to improve health and healthcare. Now, a very, very important construct as we've evolved into understanding bioethics more broadly, and that's around the issues of population health, and which is traditionally called public health. We hear this new term, population health, but really we're talking about public health. And out of bioethics, what we found is that there's a much broader issue that impacts upon populations. Most people are not patients, unfortunately, particularly vulnerable and susceptible populations. So we need to look beyond what's in our office, what's in how we interact with the healthcare delivery system, but to a broader population and how they interface. And what we've done is really try to do a really kind of comparison, analysis of how bioethics and public health ethics complement themselves. And as you may know, bioethics deals with autonomy, really important, autonomy, principle of bioethics. And it deals with justice, another principle about doing that at the individual level. And the intention to do good is principled in all of healthcare. But let's take a very careful look at this notion of public health ethics, which is a little broader and is more population-based. And as we view, public health ethics strives to improve the quality of functioning and longevity of populations, because public health is viewed by some very broadly. Public health ethics assumes a equally broad conceptual base. Public health ethics places the emphasis on the ethical problematic, that is the issue, related to the interests and health of groups, the social justice of the distribution of social resources, and the positive and social rights of individuals. The study of public health ethics requires the practitioner to effectively conceptualize and operate between the tension of individual rights and collective interests. As with public health, it also seeks to resolve the ethical problematic most efficaciously. So you see, we're talking about not only what is good for the individual, but what is good for the collective, what is right and what is wrong based upon the population, that tension that we're struggling with. And all too often, health professional students are taught how to stay out of trouble. That's the ethical dilemma. But we're not talking about how to stay out of trouble in bioethics and in public health ethics. We're talking about how to do the right thing. Very important conceptual transition. Do no harm is not good enough in the 21st century. Doing good is our ideal. So I want you to really think about these three constructs, ethics, bioethics, as we further explore cultural competency and how we improve the health and health care to the populations we serve. And I think a colleague who will join me next is Dr. Linda Behar-Horenstein. And thank you.
Thank you, Dr. Warren, and thank you all for attending today. During this presentation, I will describe how curriculum transformation, the implementation of instructional and measurement activities and research were used to study dental students' cultural knowledge, beliefs, and skills about individuals unlike themselves. I will also make the case for how this process can be applied to transforming medical education. This story begins with an understanding of culture, and that how each of us behaves is framed by an understanding of the world around us, and that people from the same cultural background can interpret health and illness in different ways. Each of us has a set of beliefs, assumptions, stereotypes, and prejudices about others that are typically unspoken, and thus are likely hidden from our own realization, but are often expressed verbally and non-verbally, and thus experienced by others. This set of beliefs can be best understood as residing into one of the categories of a cultural competency continuum. The context for the work that I will describe today resides first in recognizing the problem, that is, the incidence of profound oral healthcare disparities across racial and ethnic minorities, the lack of cultural competent knowledge, care, and treatment, and a need to change the curriculum. Upon further investigation, our research team began to appreciate that the complexity of the problem was due in part to patient-provider differences, perceived or actual discrimination, and the neglect of social responsibilities. We began to appreciate the impact of culture on belief systems, patient compliance, and that patients' willingness or ability to engage in self-care was fundamental. And furthermore, that ethnic group perspectives were central to healthcare practices and behaviors among patients and primary providers. Most important is that the challenge that's facing dental educators relative to cultural competence is not unique to the profession. This problem resides from neglect in curriculum development, in teaching and assessment, and the problem also pertains to medical education. After all, we cannot expect students and faculty to know what they have not experienced when they have not been given the opportunities to explore those beliefs. We approached this problem in two ways. First, we implemented curriculum changes, curriculum transformations in classroom teaching by assigning reflective writings and interviews and offering student feedback about the observed themes across those collective set of reflections. The first actual step, however, was to raise student awareness of their perceived level of cultural competency using the following continuum. Next, we measured changes in students' expressed viewpoints, but first we had to create a scale. We had to find a scale to measure cultural competence. However, among further investigation, we found that there was no such scale. In 2012, along with co-authors, we undertook a 2-year developmental process of an initial validation study of what is known as the Knowledge, Efficacy, and Practices Instrument for Oral Health Providers through a series of 6 steps. What resulted was a 20-item scale measuring 3 latent constructs: knowledge of diversity, culture-centered practice, and efficacy of assessment. Alongside the quantitative measure of cultural competence, we also conducted 3 additional mixed method studies to measure and describe how reflective writing assignments and interviewing influenced dental students' expression of cultural competence. And then we further tested the impact of reflective writing and assignments by different teaching methods and by the student characteristics to determine if and how they influence outcomes. Our research focused on curriculum transformation that could be used first to identify current levels of student awareness and then to evoke change beliefs. Students were assigned 2 reflective writing assignments. In the first one, I asked them to describe their personal awareness along 8 cultural dimensions: race, gender, ethnicity, social class, sexual orientation, personal ableness, faith, and first language. Assignments were graded using a rubric, and written instructor comments were also provided. In the second assignment, they responded to a similar set of questions following interviews and again received instructor feedback. Their responses to the assignment 1 questions were: define your world. What does it encompass? And what are some of your assumptions? These questions were then compared to assignment 2 questions, which were: what are some of your assumptions? And as a result of conducting the interview with the assigned individual, describe the insights you acquired about your values and prevalent assumptions in your cross-cultural relationships and the ways in which they are similar or different from the previous experiences you have had. Prior to completing the second reflective writing assignment, students were tasked to go outside of the classroom and find someone that was unknown to them on their own time along one of the 8 previous mentioned criteria: sexual orientation, religious affiliation, personal ableness, first language, social class, race or ethnicity, gender or national origin. They were asked to conduct a face-to-face interview. And I want to point out that the task that we asked them to do is not something that's typically assigned in dental or other healthcare fields. Students aren't typically asked to go out and do an interview or write reflective writings. The teaching approach for study number 1 included a lecture. The instructor provided role-play scenarios in which a student's name was randomly selected from a fishbowl, and then the student had to interact with an actor in role-play during the class. We also used automated response questions and an instructor's summary of the thematic content that appeared across the reflective writings. Here are some of the representative examples of what we learned from reading students' responses to this assignment. Define your world. What does it encompass, and what are some of your assumptions? Students described the impact of cultural group membership. Some students reported engaging in ethnic celebrations, belonging to sports teams, churches, or college groups, and they reported having a sense of affiliation and pride. Others reported belonging to cliques in schools, yet others reported no such membership and commented, "I'm pretty much sheltered my whole life." Students also reported their values for people like and different from themselves, such as, "I respect their different views," or "They're not different from me, I just don't know them," or "Sometimes I feel guilty for being white." Students also described further, "People who are like me, I can understand where they're coming from." Others said, "Everyone's entitled to their own beliefs as long as they don't impose them on others." And yet another student wrote that even in our own race and culture, individuals have various differences, pointing out that students realize that not all cultures are monolithic. Other representative examples of assumptions were, "I tend to categorize people based on how different they are, based on my own past experience," or "I try not to judge, but I do have preconceptions." For the second study, I changed the teaching approach. I provided an abbreviated overview of characteristics exemplifying cultural competence, that is, describing briefly the barriers to its development, the impact of inequity on health, and a description of the social, historical, and socio-political impacts. Then I placed students randomly into small groups and asked them to discuss questions designed to reveal their cultural beliefs. For the third study, I exclusively used small group discussions and provided questions to student groups such as, "Tell me, what does a cultural competency look like?" And, "Would you please provide examples of when you experienced culturally insensitive communication? How did that make you feel?" Students were asked to place the replies on paper measuring 30 by 42 inches, and they posted their replies on the wall. Using this museum approach, students were asked to walk around the room and view each other's responses. Similar to the previous two studies, I summarized the themes across their collective writings to the first reflective writing assignment. To analyze the text of student responses to both reflective writings, we used a linguistic inquiry word count program known as the LIWC. This program calculates the degree to which people use various categories of words, as well as when text uses positive or negative emotion, self-references, and causal words, and it provides a comparison of words to internal and user-defined dictionaries. It counts the number of dictionary-specific words and divides that number by the total number of words that have been recorded. Throughout this curriculum transformational process, I use purposeful instructional activities to challenge students' personal biases while simultaneously exposing them firsthand to the lived realities of others through interviews. Notably, across all three studies, we found that students recognized unconscious biases. They reported an increase in personal cultural competence. We saw this quantitatively because there was an increase in word count and the number of words used in the second writing assignment that demonstrated active reflection in which students questioned previously held assumptions derived from their own social world. We also found that the participants, of which there were over 270 across the three studies, engaged in reflection and showed changes beyond course content. Overall, using matrix coding, the results showed increased student awareness concerning how people with influence on their lives impacted their attitudes by gender, by majority-minority status, and by some of the 8 interview categories, including religion, social class, race and ethnicity, and sexual orientation. For example, in spite of strong religious beliefs, Melissa, an underrepresented minority female, supported same-sex marriage, and she surmised that being raised in the presence of others who were less religious than her family enhanced her openness. Another underrepresented minority female, Cherise, questioned her suppositions about single-parent households. Learning that her interviewee grew up with one parent and that parent had been diagnosed with HIV, Cherise recognized that perhaps a single parent could fulfill the role too. Other representative examples included Stephen, a white male who discovered that gender did not change the formation of beliefs and practices among males and females, and Norman, a white male who became aware of his tendency to make generalizations and conceded that this practice was unwise. Regarding the impact of faith, Joe, an underrepresented minority male, gained a better understanding of a person from a different faith, culture, family background, and school environment compared to his own, and he asserted that making assumptions about people from different cultural backgrounds was really ill-advised. And finally, regarding race and ethnicity, Maria, a white female, confessed that she thought of African American students as underachieving, and that she had derived such attitudes from family members by witnessing personal behaviors among some African Americans, and that as a result of conducting the interview, she realized that she had been very biased. Across 3 consecutive studies, the findings showed statistically significant and qualitative differences. The findings showed that students began to rethink previously held assumptions about their cultural beliefs, that they experienced an increased awareness of their unconscious biases, which resulted in a change in cultural beliefs. And all of this occurred with just 2 reflective writing assignments and an interview. The challenges for medical educators include the need to amass evidence-based findings that exceed the dependence on survey-only results, and to analyze the nuanced changes that may be occurring across participants. Other challenges include trying to promote a recognition for how culture influences individual perceptions of health. Our work fell short of what I had hoped to demonstrate, that is, how curriculum transformation might impact primary provider-patient interactions, and if the documented textual changes that we saw in cultural competence could be seen in communications. In this regard, Meharry Medical College is invited to take on a leadership role and extend our research. This next step would be to observe student-patient interactions early and later in their clinical training and document what the communication looks like. For example, medical students could wear GoPro cameras to provide researchers with an opportunity to observe and then classify their interactions and codify what cultural competent communications look like and do not look like in real time. Other suggestions for curriculum transformation include placing medical and dental students together in federally qualified health centers to experience healthcare disparities and to address the healthcare needs of vulnerable populations. And then engaging medical and other health professional students in interprofessional educational projects that are designed to respond to community healthcare problems. Our studies suggest 4 particular points relative to developing cultural proficiency that have implications for transforming medical educational curriculum. First, the importance of acknowledging the historical persistence of educational, social, and economical gaps cannot be understated. Second, to ensure that communication with patients promotes patient understanding of their medical condition and how to execute self-care, we believe this is best accomplished by observing and studying the quality of interactions. Third is the importance of examining individual beliefs and practices without judgment and then providing curricular interventions to correct erroneous beliefs. And fourth is moving from viewing culture as a problem towards embracing, esteeming, and appreciating its influential role. Finally, in conclusion, efforts to enhance cultural competence in medical education could also focus on forging partnership plans of care that ensure that patient-provider understanding. In this regard, patient providers should explain their understanding of the patient's need for care. Correspondingly, would be to ask to be able to focus treatment and solidify the patient's intent to comply, in part by asking the patient to restate the treatment plan. And finally is the importance of developing care plans that are respectful and responsive to patients' cultural mores, traditions, and beliefs. I want to thank you for listening today. I do wish to point out that I am now Professor Emeritus, having recently retired from the University of Florida. Thank you.
Great. Thank you so much to all of our presenters for presenting today. It looks like we'll be moving into our question and answer session just a few minutes early. For our attendees, if you haven't already, please feel free to enter any questions you may have for the presenters into the chat box, and we'll be reading some back for our presenters to answer. The first question that we have, I believe, is for Dr. Warren. In regards to public health ethics, could you provide an example of the tension between individual rights and collective interests?
Sure. My daughter, I don't want my daughter to be immunized. I don't want her to be immunized, but she has to go to school, and the school requires immunization. What do I do? The individual right says I have the right to determine what is best for my child. The public health ethics is that what about the health risk that she poses when she enters the school system? So it's that tension. What is good for her may not be good for the collective. It happens all the time across spectrums. That's the most clear and blatant example of that tension. What is good for you versus the individual? Our collective interest versus individual rights.
Great. Thank you, Dr. Warren. And it looks like our next question is for Dr. Behar-Horenstein. What data do we have about failures to access services by members of the LGBTQ community and others with insurance coverage?
That is not a question that I can readily answer. I can tell you that there is that the LGBTQ population among dental students does not feel that their educational experiences are responsive to themselves or to patients.
Carol, would you restate the question?
Oh, sure. The question was, what data do we have about failure to access services by members of the LGBTQ community and others with health insurance?
Thank you. That's an area that the new work in health services is trying to do. They're trying to use the electronic medical record to get enough data, whether structured or unstructured, to answer questions about access to care and using insurance as one of the variables. I think that there are studies out there, but they have not yet been geared towards gathering data on the three populations that we're concerned about. That's why there's so much interest in looking at how do we use the electronic medical record within the medical education and or health to determine access issues, and lack of insurance would be an access issue. So I think that's an ongoing issue that we are trying to address.
Great. Thank you, Dr. Matthews-Juarez. And it looks like our next question, I believe it's for all the presenters. And it says, there's a growing use of the term cultural humility. Is there a role for this term in medical education?
Oh, this is Dr. Behar-Horenstein. I think absolutely. And I think that one of the things that we learned from our 3 consecutive studies was students became very humbled when they were interviewing people unlike themselves that began to realize just how their preconceptions and assumptions and stereotypes had guided their thinking in the absence of experiences with people unlike themselves, and they became very humbled.
Well, if you can tie it to humanity, we can always be humbled by an event or show humility, but it's all a part of sensitivity and looking at it from a microaggression position, and to try to wrap that into the idea of having the desire to understand what you see, having the awareness to tie it to knowledge, and then tie knowledge to a set of skills that allows us to demonstrate that we are sensitive, that we care, and that we're going to do the best thing possible. And I think Dr. Warren made an excellent point when he says it's more than do no harm. It's about doing the right thing. And so if you can tie cultural humility into a continuum of care that leads you to a set of skills that can be measured, and that there are metrics that show that the way in which you treated a patient improved the outcome of their diabetes from 9 to 7, or from 9 to 6, or that you encourage someone to get their kid inoculated for the public good. I think then you can begin to say it is relevant. I think any time that you can get people to be sensitive and care about others is really 100% above whatever you would have gotten in terms of not being careful and caring for the person that you see in front of you.
This is Rueben Warren. Implicit in what Dr. Matthews-Juarez is saying is an appreciation and a recognition for the other. Sometimes we forget that the other is a critical important of our well-being.
Mm-hmm.
And I want to stress,
Thank you all.
this is Dr. Behar-Horenstein. I want to stress relative to this presentation, it is incumbent upon us in the curriculum transformations that can be provided in medical and other healthcare professions to bring this issue to fruition. If we do not give students and faculty opportunities to reveal their beliefs or to observe them in practice, we have no knowledge with which to help them grow.
That's absolutely true. That's really what clinical transformation is all about, and this new push on changing medical education in a way that students feel that they are part of it and they can participate in it. Rueben, I'm sorry. Dr. Warren, I'm sorry, you were about to say something.
No, you said it.
Great, thank you all so much. Our next question says, how prevalent are standardized screenings and assessments on homelessness, LGBTQ, and or migrant workers within the primary care setting?
It depends on the part of the country you're in, and how I suppose it occurs often for homeless persons in federally qualified health centers, private practices that are moving towards patient-centered medical homes, probably don't do much. Access is a big issue still for migrant workers, but there is a migrant clinical network that's across the country and across the nation. Fenway in Boston have many clinics. The homeless, the organization that's putting this on, have clinics across the country, but it's still a problem, because, primary care docs who, for instance, if you lived in the western part of this state, you probably don't have primary care physicians who want to see the population that we're talking about. So access still is an issue in primary care settings. Not so much maybe in federally qualified health centers.
Great, thank you, Dr. Matthews-Juarez. The next question says, did you test the clinical faculty in the development of the curriculum models that you tested?
I assume this question is for me, Linda Behar-Horenstein. We did test the faculty in the development of a cultural competency scale. And we have reported outcomes from those findings in several studies, which are listed in the reference section of the slides.
Great, thank you. And the next question says, do you have any thoughts on cultural competency as a long-term educational process?
I'm sorry?
The
Repeat
question
that,
says,
Kirk.
sure. The question says, do you have any thoughts on cultural competency as a long-term educational process?
It has to be. It has to be. We're not going to reach out. I mean, if you look at the fact that we all come from different environments and we're all impacted by different culture, and we all see people differently, and we have to use a looking glass or lens to figure out who, if we're in this business of clinical care, to figure out that the person who sits in front of you is very similar to you. The difference, they may be white, they may be black, they may be Native American, they may be Appalachian, they may be Asian. So you've got to figure out how you're going to talk and reach the individual in front of you. Or they may be from your racial ethnic group, but not from your particular economic group, or not from your particular geographical community. So yes, it should not be an issue anymore. It should be so embedded that we don't even think about having a discussion of cultural competency. Now, Armin Weinberg is on this call, and Armin and I wrote a little pamphlet called Cultural Competency in Cancer Care. And we would just think that that would be just a non-starter for providing care to people with chronic diseases, that you just have to have that. And I'll close with that. Armin, if you wanted to say something, that'd be fine, but in the chat box. But what do you think, Dr. Behar-Horenstein? What do you think?
I absolutely agree with you, Dr. Matthews-Juarez, and this was the case that I tried to make, that we analyze students' interactions early and then later in their clinical training by use of GoPro cameras, that, we've measured it through the students' interviews and through the reflective writings and by observing them in classroom interactions. Now we need to take it to the clinic and see what's happening. So do the textual changes that we see and the attitudinal changes we saw, do those sustain? Are we going to see them later on? Or was it just, well, this is what we're telling the researcher? I don't believe that it is, because the 3 studies were separate with 3 separate dental classes. And I think it needs to be infused into every aspect, whether it's preclinical or clinical education. It needs to be part and parcel of every discussion and learning experience that students have. And it can be, with willingness.
The University of Southern California is doing on microaggression and looking at cultural competency. So we'll get some data out of there. But Meharry Medical College for 42 years, have focused their whole structure, whether it was the nursing school, whether it was dentistry, whether it was medicine, now public health, on the idea of culture being a real factor in the delivery of care. And our students have come away and been measured around how culturally competent they are in any of the settings that they go into. So I believe that it's no doubt about it that majority schools have to begin to think about this seriously and work towards having measures that really delineate what a curriculum should look like that deals with people from diverse backgrounds, whether it's racial, ethnic, or geographical, or economic.
I'd like to comment, Dr. Matthews-Juarez, that there's a reluctance at some of the majority schools to do so, because most faculty and students, for that matter, see themselves as culturally competent, and engaging in these kinds of discussions with them are fraught with a lot of challenges.
That's true. I agree with you.
Great, thank you all. And it looks like we do have a response from Armin Weinberg, who says that Clinical reinforcement by the mentors was key, which is why I raised the question about faculty attitudes, etc.
Mm-hmm.
And let's see, looks like we have one more question. Is there any data regarding the percentage of LGBTQ populations working within primary care? How can this population be benefited from greater representation from this community?
Catherine can talk a little bit about what the Fenway group is doing. You know, I think that we can't always rely on such a small group to make sure that the information is being transmitted. Like we can't rely on African Americans to make sure that, that care is going to be provided and that we're going to have all African Americans to do this kind of work. It really talks about a societal change and the ability to understand that everyone is equal, everyone deserves the best chance ever, and that we're all standing on common ground. And I think if we come to that notice, then the data will become more universal and be more centrist in terms of what we know about how the three different populations are being treated.
Great, thank you so much. It looks like that is all of the questions that we have submitted at this time. If there are any more questions, please go ahead and feel free to enter them into the chat box. All right, we have none come in just yet. If we do have any more questions come in, we'd be happy to submit those to the presenters for written responses. Thank you so much to all of our presenters today for presenting, and for everyone who has joined the webinar, thank you for attending today. Presentation materials and a link of the archived webinar will be available on the Council's website at www.nhchc.org within 3 business days. A survey for evaluating today's webinar will open in your browser at the close of this session. We very much appreciate your feedback, and we appreciate your time today. Thank you, and the webinar is now closed.